Hi, I'm Dr. Lindsay Remy. I'm a sports specialized orthopedic surgeon, and one of the things I see a lot in clinic is patellar instability. That's another way of saying when somebody's kneecap won't stay in place. This is something that I see patients of all ages experience. It most commonly happens to children and adolescents, particularly those people that are involved in cutting, pivoting, and those more athletic type endeavors. Sometimes it happens for the first time because of a trauma, but sometimes it happens because the knee is just built in a way that makes it more likely to happen. So if you're watching this video, I'm guessing it's because either you or someone you love has had this happen, and you probably have some questions about what it is, how do we treat it, how do we get you better, how do we make that kneecap stay in place. So that's why I made this video. First of all, let's look at the knee. This is the knee, and here's the kneecap, and here is the groove that it rides in. So we call this the patella, and this groove of the femur is called the trochlea. So people that are at high risk of kneecap instability episodes, often it's because of the way they're built. So they may have what's called patella alta, which is where the kneecap sits a little too high, so it's not constrained by the groove. Or they may have something called trochlear dysplasia, which is when this groove is built too shallow, so it doesn't contain the kneecap quite as well. Or they may have a relationship problem between where this tibial tubercle is and where the center of the groove is, so that it's off at an angle. Or the whole angle of their leg might be off with a knee valgus, which is a knock knee, or a knee rotation problem. So bony alignment can impact this issue. The other reason people may have kneecap instability problems is if all of their joints are loose. We see this in hypermobility conditions such as Ehlers-Danlos syndrome. So young age, anatomy, being ligamentously loose. And then the fourth thing is if it's happened once, it's more likely to happen again. So when somebody has only had their kneecap pop out of place and it's gone back in one time, it may not happen again. It's about 50-50. If it's happened twice, the odds go way up. And once it's happened 3 or more times, it's almost certainly going to keep popping out of place. When the kneecap pops out of place, unfortunately, it not just causes you pain, but it can actually do damage to the underside of the kneecap. What this blue paint in the model represents is cartilage. Cartilage is the slippery, smooth surface on the undersurfaces of our bones inside the joint that lets them glide. Once that is damaged, it is very hard to fix that. We have options surgically to improve cartilage problems, but the best treatment is to prevent that from happening. So we really want to stabilize somebody's kneecap before it has already done articular cartilage damage. So when I'm deciding if somebody needs surgery, one of the main factors that I'm looking for is, has this happened more than one time, or is there already damage to the cartilage? If this kneecap has popped out of place a couple times, or there's already damage to the cartilage, then unfortunately, surgery is probably our best option. If this is a first-time episode and your cartilage is healthy, then non-surgical strategies are much more likely to work. Let's talk about what those non-surgical strategies are. We're talking bracing, physical therapy, and a season of healing. So after a dislocation, you may need a few weeks avoiding your sport to try to give yourself time to heal and get back to your former activity level. Let's talk about what the surgical options are. One of the most common surgeries for this problem is called an MPFL reconstruction. That stands for medial patellofemoral ligament reconstruction. And that's such a big, long name that we will always use the 4 letters MPFL. This is a very successful surgery with about a 90% success rate. So less than 10% of people will have any further episodes of feeling like their kneecap is shifting partway or all the way out. But like all surgeries, it comes with some risks that I'll talk about in a minute. Some people need their MPFL reconstruction done with something else because of the complexity of their knee. So for example, if you have a really severely formed groove, so where it's a bump instead of a groove, we may need to do a surgery called a trochleoplasty. Or if you have very tight tissue on the outside of the knee, pulling the kneecap to the outside, we may have to do a lateral retinacular lengthening. Or if the position of your bones is such that I need to move the tibial tubercle, there's a surgery called a tibial tubercle osteotomy. I know that that's a lot of information, but the reason I wanted to go into that is so you know that your surgery would be tailored to your individual anatomy. And while the MPFL reconstruction is a great surgery for a lot of people, sometimes it's not enough, and people need some other procedure with that in order to give them the best chance of only needing one surgery to have a good outcome long term. The other thing that might need to be added is some type of surgery for the cartilage. So if the cartilage had already been damaged, then we might need to go in after a loose piece and do a loose body removal, or take some cadaver cartilage and try to fill a pothole, or even do a really advanced technique such as matrix applied autologous chondrocyte implantation, also known as MACI, where we can regrow your own cartilage cells to fill a hole of missing cartilage. What I want you to know out of that is that there are options to treat your cartilage if you already have cartilage damage. Of course, all surgeries come with some risks. Let me go through what the risks of this specific surgery are that you need to know about. Of course, there's a risk of surgical site infection. This is only around 1%. There's a risk of lower extremity blood clots, which would mean a deep vein thrombosis or a clot that could travel. That's about 0.1%. There's a risk of knee stiffness. Usually that's something that can work itself out with physical therapy, but about 5% of the time it might need a reoperation or a repeat procedure to address stiffness. There's a risk of your quadricep muscles, your thigh muscles, being weak after surgery in a way that delays your rehab. Lots of people have some degree of weakness. We would only consider this a complication if it delays your progression, and about 10 to 20% of people will have this. There's a risk of numbness on your skin around your scars. This is incredibly common. About 60 to 80% of people will experience this. It is usually temporary, but it can be permanent. There is a risk of hardware-related complications, either in surgery or after surgery, with symptoms around where those fixation points are. And then, as I mentioned earlier in the video, there is a risk that your kneecap becomes unstable again in the future. And this risk is low, and this is why I work really hard to try to tailor your first surgery to hopefully be your last surgery. The other thing long-term is that people that have had a kneecap that has popped out of place are at higher risk of arthritis under their kneecap in the future. So this is a risk that's hard to put a number on, but I think people should know that they're at slightly higher risk of having long-term arthritic changes, especially if their kneecap had dislocated many, many times before they ended up having stabilization. Let's talk a little bit about what your recovery after surgery is like. This is typically an outpatient surgery where you're going home the same day. If it's an MPFL reconstruction without any bony work, then you could put your full weight on your leg right away. If I have to add something like a trochleoplasty or a tibial tubercle osteotomy, then you would be non-weight bearing initially and gradually progress as your bone heals. For the first 6 weeks, you can expect to be in physical therapy, but also be restricted during the day with a brace and crutches because you're waiting on your muscles to catch up and recover from the surgery. Around the 6-week mark, most people are ready to start weaning out of that brace and progress in their physical therapy. Of course, there's variability from one person to the next on the exact week that they get out of the brace, but usually around there, and they're starting to focus on more and more strengthening with their physical therapist. I would say on average, around the 3-month mark, most people are back to doing the things that they want to do. They're back at work, they're back to light hobbies. They may even be able to go for a more gentle hike or some light sports. Cycling would be a good example. But you're not ready to really run, really jump, really do anything too strenuous yet. On average, that starts around the 4-month mark. And between month 4 and month 6, my athletes are working towards building up their agility, their speed, and their strength to where they can meet all the necessary milestones for return to sport. For this surgery, as well as for other knee surgeries, I believe in a holistic sport preparation process that includes working with your physical therapist to measure your strength, your balance, your agility, and really make sure we've reduced your risk of re-injury as low as possible. I would say on average, people are returning to sports around the 6-month mark, but depending on your individual surgery your preoperative fitness and what type of sport you're going back to, it certainly could be a little sooner or a little longer because we want to keep you safe. I hope this video has been helpful to you. Please bring up any additional questions or concerns in your office visit, and I look forward to talking to you about them.